You will find it interesting that over 50% of Americans will contract a sexually transmitted infection during their lifetime. With an STD, it is common to develop skin issues. Today, our focus is going to be on dermatologic issues pertaining to syphilis, where close to 130,000 new cases are diagnosed every year in the United States. To better understand syphilis and managing dermatologic complications, we are fortunate to have one of the leading dermatology experts on the topic. Our guest today is Dr. Theodore Rosen, who is an expert in cutaneous manifestations of sexually transmitted infections. He served both as the physician in chief and chief for the City of Houston Night Walk and STD Clinic for 25 years and the designated STD control officer for the Houston VA Medical Center. Currently, Dr. Rosen is a professor at the dermatology at Baylor College of Medicine in Houston, in Texas. He is a past vice president of the American Academy of Dermatology, the AAD, and the Texas Dermatological Society. He is also a past president of the Houston Dermatological Society. Dr. Rosen, I'm so happy to have you here on the Derm Club podcast. Thank you for your time.
My pleasure.
So I'm going to get started here. Let's start off just, some basics, and then we will go from there. Why has there been a resurgence of syphilis and other STDs in recent years, even despite the fact that we have a lot of education now, we have resources? Is it that we are more diligent about testing? Can you please share with us your thoughts on this?
So before I answer your question, let me just make one brief comment, which is this, because people often ask me, what does this have to do with dermatology? Do you see skin cancers and acne? And the answer is yes. I think we have to remember that in years gone by, dermatologists were also called syphilologists.
Yeah.
And a lot of the early work, including research on STDs, was done by dermatologists. And reality is, since, as you mentioned in your intro, a lot of these, especially syphilis, have cutaneous manifestations, who better than the dermatologist to be interested? Unfortunately, it's not quite as remunerative as, let's say, botulinum toxin injections and fillers and so forth, but it is actually within our wheelhouse. And if my office was next door to OB-GYN at my institution for, oh my gosh, almost 20 years. And they would call me over to look at genitalia every single solitary day, because if it wasn't classic lichen sclerosis or classic herpes, they were sort of lost. So, it is within our in our wheelhouse to be interested in STDs. It's skin after all, even though it's between the navel and the kneecap. So at any rate, just with that brief introduction, and remember, one of our leading journals, the Archives of Dermatology, JAMA, now Dermatology, used to be Archives of Dermatology and Syphilology. In fact, there's a long history of all of our journals, including the word either syphilis, syphilology, or genital dermatoses. So it should be in our wheelhouse. So why is there more STD? I don't have a simple, straightforward answer on that. I think you have to go back a while and think about really the 1970s even, and the women's liberation movement, and the sort of freedom of we can do what we want to do. And that's not just women, it's women and men with each other or with people of the same gender, along with the use of drugs, which became pretty all-pervasive. And then you go along a little later and it's easy to get contraceptives now even if you're not of age, you are allowed to get those without parental consent.
Mhm.
So you don't sit and worry about getting pregnant so you can have sex. Now, of course, the contraceptives don't do a darn thing to prevent sexually transmitted disease, but it takes one worry off the table, along with or instead of or using barrier protection, which is, very inexpensive these days, has to be used properly. But so I think it really goes along with a sort of societal evolution. And then you think about, well, we have a lot of education, but I have to tell you, not that long ago, this is a personal story. I have a pair of identical twins, and they were taking the mandatory social health class in their high school. And they came home one day and they said, Dad, the teacher in the class said that the virus of syphilis can't be spread by oral sex. And they already knew it wasn't a virus, it was a bacteria, and they knew about the oral manifestations because they looked over my shoulders while I was making up my PowerPoint slides to give talks on STDs. And I said, who's teaching that class? Well, it's the football coach. And in a lot of schools, this is not unique to my kids' high school. In a lot of places, those kind of what should be very educational classes are relegated to individuals who need to do some teaching but aren't really educated in the subject matter. It's an interesting follow-up. So my kids went back the next day after we talked about it, and they raised their hands, and one of them, the louder one, said, Coach, you were wrong. It's a bacteria, not a virus. And did you ever hear of mucus patches and condyloma alata, which can occur in the mouth, which would be highly contagious? He looked like a deer with a headlight shining in his eyes and basically said, well, if you're so damn smart, why don't you teach the class the rest of the year? So he got out of his obligation and they taught the STD class for the rest of the year. So, I mean, I think it really isn't a lot of education. And then you think about very, very, very recent days, and I'm talking pandemic now, there was a worldwide shortage of condoms because 3 of the 4 biggest condom manufacturers had to shut down because all the factory workers had COVID. So, there weren't condoms. The STD clinics, which are a variable quality anyhow, only 8% functioned since 2019 in a normal fashion because they're not really designed for social distancing, for example. They didn't have the resources to supply masks for everybody who showed up, et cetera, et cetera. So very, very few were open properly, and a lot of them just shut down completely. 25% of all the STD clinics in the US completely closed. So, and despite our thinking about, well, we don't want to get too close and we have to wear masks, the reality is a lot of people were staying home a lot with their significant others who might or might not be their spouses. Hey, come on over and let's just stay together for the next 3 months. Well, what do you do when you're done with your work? So we really thought maybe there'd be a decrease in STDs, but we don't have the final 2020 statistics yet. But at least from congenital syphilis, we do, and the preliminary statistics show it went up from 1,808 cases to over 2,100 cases.
Wow.
And I think that's going to mirror an increase in lots of STDs while we were in the middle of this pandemic. So
you
there's
must
actually
be very busy.
there's actually an interesting paper from Italy. The same province in Italy that was the hardest hit by COVID not only had they had a slight increase in STDs. They didn't close down their STD clinics. And the last sentence or so in the paper says, not having sex is not an option. So the bottom line is, it's a lot of factors. And I think the last thing I'm going to say before we talk about some other issues is remember that over 50%, you use that statistic, 50%, but more than 50% of STDs occur in individuals 15 through 24 who feel they're invincible, right? I'm not going to get this. It's not going to happen to me. And so you have a highly susceptible group of people who are engaging in what their raging hormones tell them to do.
Very interesting. I have a question. First of all, I have to tell you, I think I had the same experience as your twins. I remember having the same exact experience when I was back many years ago. And it's pretty funny. I think maybe they should go around and teach at maybe your twins should teach at many of the high schools because I'm sure it's a common trend. But I want to ask you a question, and it might be a little controversial. Is it true that there's a higher rate of STDs or specifically syphilis in people who are having sex with the same gender?
Yes, well, yes and no. Not women and women, but men and men. Disproportionate, about a little under or over, depending on the year, of syphilis cases are seen in gay and bisexual men. And I think that goes back to two factors. Number one is sort of a cavalier attitude of not really making use of things like barrier protection in an optimal fashion. And then I think we saw a decline in STDs, including syphilis, with the advent of HIV. But now, because of really much better therapeutics, I mean, there's a drug that was just recently approved. It's a shot every 6 months, and there's one that's going to be less than that. I mean, so I think the fact that we have very good HIV therapeutics makes people less concerned about catching that, and so they'll engage in activities which are conducive to acquiring STDs in general and syphilis in particular. And the statistics bear that out. The other thing is there's two groups at high risk. One is gay and bisexual men, and there's a disproportionate number of syphilis cases in individuals who come from the skin of color group, particularly Black and Hispanics. STDs in general also are, so that would include things like chlamydia, gonorrhea, are more common among other minority groups like Alaskan natives and Pacific Islanders who are under the auspices of the U.S., like U.S. Samoa and Guam. So we do have, and I think that probably relates to even worse education than I was talking about in certain communities. And I think with better education, a lot of this could be helped. It's never going to be zero. The CDC at one point around the year 2000 was talking about the elimination of syphilis in the United States because the number of cases and the rate per 100,000 adult population had dropped so low. They were talking about the elimination. Well, it's not. You're never going to eliminate it because you're not going to stop sex, and you're not going to stop.
Now we went the opposite way.
Yeah, you're not going to stop people doing things that are facilitate the acquisition of STDs.
What is the classic presentation of syphilis that patients or clinicians should look out for?
So I'll describe that, and then I'm going to throw a monkey wrench in that whole. So, syphilis goes through stages: primary, secondary, and if it's not treated, tertiary stage. So the primary stage is the chancre, the painless, usually solitary, clean-based ulceration on or near the genitalia. And it's indurated. It has substance to it. And that classic description is absolutely still true. However, one of the minor venereal diseases, lymphogranuloma venereum, which every medical student learns about in medical school and promptly forgets, because unless you work in an STD clinic, you're not going to see it. And even now, if you work there in the United States, there are about 12 cases a year, or there have been up until very recently. But it's changed. It's the same bacterium that always caused it, but it's changed. It used to be that it would be primarily enlarged, painful lymph nodes in the inguinal area. And then it became a perirectal disease. And now it's presenting as genital ulcerations that, for all intents and purposes, look exactly like primary syphilis. So that's a problem. All right. Then what happens is you have the chancre of primary syphilis. It's painless. People may not seek attention. It spontaneously goes away. Well, people say, whew, I'm saved because there's nothing there anymore. And then a month or 2 or 3 later, they develop secondary syphilis. And that can present classically as a widespread erythematous papillous squamous eruption, can look a lot like psoriasis, doesn't itch, doesn't hurt, just looks bad, which might drive people in to seek medical attention. If I had maybe a quarter for every patient I've seen over the years who was like that, who went to their primary care physician, who got a tube of steroids, I could retire years ago. Anyhow, so, but then again, secondary syphilis can present in all sorts of ways. You know, typically palms and soles are involved, but it doesn't have to be. It can be the trunk, can present as painless, non-scarring hair loss, so-called moth-eaten alopecia, because looks like a moth has been eating the hair like it would eat the fur on a fur coat or something. It can present just with oral lesions. I mentioned those earlier. Shallow erosions, mostly on the tongue, sometimes on the soft palate or the buccal mucosa, called mucus patches, or condyloma lata, which are thick. They kind of look like venereal warts, but those can be on the inside of the mouth. And then the other thing that's really interesting about syphilis is its protein manifestations in the secondary stage. So you can have really horrible looking things, big, large, heavily crusted or ulcerated lesions that don't look like typical syphilis. But it's syphilis, and you have to have the proper index of suspicion to go ahead and either biopsy and find a gazillion plasma cells or do serologic tests for syphilis. And it can present as lumps and bumps that don't at all look like the typical syphilis, particularly on the face. So it can literally, it's one of those diseases, syphilis, sarcoid is another one, which are literally called the great imitators because it can mimic so many other things. And then what happens is secondary syphilis goes away in a month or 2, and oh my God, the rash is gone. I don't have to worry about it. And then it reappears because there's a spirochetemia, the causative organism gets in the bloodstream, and it goes to places like the central nervous system and the heart and causes problems later on. Now, those are past the purview of dermatology, but it's interesting that both the primary stage and the secondary stage spontaneously resolve in most individuals. And unless they're diagnosed at those times when they're active, you can end up with real problems later on down the road.
You know, it's interesting because I actually had an experience of my own. I saw a patient who came in to the ER with a pemphigus-like presentation of secondary syphilis. And I actually wrote a case report on this because, like you said, it is a great mimicker and it could have been easily missed. He did not have the classic symptoms or presentation at all. And he neglected to tell us that maybe 2-3 months before he had this primary painless chancre, and all we were seeing on presentation were like a bullous-like eruption. So it took a lot of digging and tests to figure out that what he had was secondary syphilis.
Right, and think about this. What if the primary comes from anal sex and you have a painless lesion that occurs in the perianal skin? Nobody looks, it's really hard to look at your perianal skin. So on your genital skin, you might see it, but if it's in the backside, they're not necessarily hiding the fact that they had a lesion. The patient doesn't know. So they might not be able to give you the full history.
Yeah, and it could be easily missed. So do you find that treating earlier or earlier detection is helpful? Like, I obviously it eliminates the possibility of the involvement of other organs, but in terms of preserving, say, the skin and avoiding scarring, do you think it's beneficial to have early detection and early treatment?
Not specifically for that reason, because most of the lesions of syphilis heal without any mark at all. In skin of color, there might be some post-inflammatory hyperpigmentation, but that's kind of about it, and that'll fade with time. The reason to diagnose and treat early is to prevent the transmission to others. That's really the reason to get it early, and of course to prevent later consequences. But it's really as a societal epidemiologic thing. And part of the, since I mentioned that word, part of the other problem, in the last couple of years is that all the public health officials, justifiably so, because I think humanity was threatened by COVID-19, but a lot of the public health officials have been pulled from STD duties and contract tracing to contact tracing of COVID-19 and dealing with the fallout from that pandemic on a societal basis. So not only were STD clinics closed, but all the public health officials, or many of them, have been taken off of that sort of follow-up, which is how you find where this started. You've got an index case, but they didn't get it by spontaneous combustion. I think that theory's gone out of vogue for about 400 years or so. So they had to get it from somebody, somewhere. And unless you sit in and really interview people, and then, think about the incubation period. It's typically 21 days, but it can be as long as 90 days. So that's 3 months. If you asked me what I did 3 months ago, I don't know I could particularly tell you. So when I worked in the STD clinic, I sat in on some of those epidemiologic tracing interviews, and people were genuinely, for the most part, willing to cooperate. But when you say, okay, this could have been as long ago, your unprotected sexual intercourse exposure could have been as long ago as 3 months, the patients would say, well, I don't know what I did. I don't remember who I was with 3 months ago. I can tell you last week or maybe a couple of weeks ago. But if you have a lot of anonymous partners, it really is very, very difficult. Or you could have a description like this. Well, yeah, it was a tall guy who wore a red shirt at Sullivan's bar. Well, yeah, that's really helpful, isn't it? So it's difficult. It's really, really, really a difficult thing to say from the index case where this came from. And that contact tracing is very important from a let's get rid of this standpoint. And that's why it's so fraught with difficulty, not for a lack of trying, but just the reality of the thing, that's why we really aren't ever going to probably eliminate this unless there's a vaccine somehow that would take care of it.
So that brings us to our next question. Well, actually, two other questions. If a patient is confirmed to have syphilis, what do you recommend for the partner?
Okay, so if the partner is known, it's 9 to 90 days, but it's usually 3 weeks. So if you haven't had a partner that's 3 months ago or one recent, and you've been with this person or maybe these two people, you have a limited set of partners that fit that general 3-week incubation period. So first of all, the index case and the partner need to be tested for HIV, because HIV should be routine when any other STD is encountered, because you had an unprotected episode where you caught one thing, you certainly could catch the other. And some things, not necessarily syphilis, but herpes in particular, genital herpes, has been shown to facilitate the acquisition and transmission of HIV. So as a general rule, everybody should be also tested for HIV and then retested perhaps a few months later. For the partner, if you have a contact and they're within the window of incubation and they're not allergic to penicillin, it's probably a good idea to get a preventative dose of benzathine penicillin, which is the treatment of choice. And I might add, just parenthetically, we are extremely lucky. If you think about the history of infectious diseases and how you have a treatment, but then the treatment doesn't work. So then we have to get a new treatment. I mean, that's what gonorrhea has gone through. Back when in the day, we used to treat gonorrhea with amoxicillin or ampicillin and probenecid. First, it was just the penicillin derivative, then probenecid to prolong its half-life. Well, that didn't work. So then we used tetracycline. That stopped working. So then we used fluoroquinolones. Those stopped working in a substantial number of people.
Because of all the resistance?
Yes, resistance. And once you have resistance in one place, eventually it's going to be worldwide. And so we're down to third generation cephalosporins now, ceftriaxone. But there's now ceftriaxone resistant Neisseria gonorrhea in 11 countries, major countries around the world. And it's been seen in a few cases in Hawaii and California. Well, what are we going to do next? I mean, there are new drugs that are in development. They're in phase 3 but we've been chasing gonorrhea, chasing. So by contrast, we're still lucky that benzathine penicillin and the fallback drug, which is doxycycline, both are extremely effective for syphilis. We haven't had a loss of efficacy. We haven't had a development of resistance, which is a miracle. It's literally a miracle.
Why would that be? Why would you have resistance for one STD but not for the other?
Well, I think part of it's the nature of the organism. Some develop resistance more than others. Part of it relates to the treatment. You're overwhelming treponema pallidum when you give 2.4 million units of bicillin. You're killing it and then killing it over and over and over again. That's such a high dose. And part of it is the number of cases. And yes, your syphilis of all types, primary, secondary, tertiary, early, latent infectious, and congenital syphilis is that 130,000. But in terms of primary and secondary syphilis, which are the most contagious forms, in the U.S., it's just under 40,000. Well, that's a lot less than 600,000 cases of gonorrhea. Mm-hmm. So you have more cases, you have more organisms exposed to antibiotic, more likelihood of resistance. It's just a numbers game.
Well, thank goodness for science, right? Because it allows us to keep creating new drugs to eradicate or eliminate or improve disease. And if we didn't have that ability, we would have even higher increases than we see now.
Well, just a quick, this is also a parenthetical remark. It's off the exact topic, but for all the listeners, the World Health Organization says that by the year 2050, unless that includes us, and includes all healthcare providers who prescribe antibiotics. So, not pathologists or radiologists necessarily, unless they're interventional, but all of us, derm, primary care, gynecology, pediatrics, unless we kind of curb our ways with giving antibiotics as freely as we do, the World Health Organization says by the year 2050, we're going to be in a position where we'll have not just 700,000, we'll have 10 million cases of resistant, pan-antibiotic resistant infections in the world. And a person will die every 3 seconds from a resistant organism. So, we really need to be very careful about our use. We need to be good stewards of antibiotics. Because the number of syphilis cases is relatively low, it kind of forces us to be good stewards. But for everything else, we do need to still be very, very careful how we use those. And in dermatology, if you think about, well, where do we use antibiotics? Rosacea, acne vulgaris, hidradenitis suppurativa, folliculitis. There's a lot of places we're sort of tempted to use antibiotics for long periods of time. And then you turn that patient into a little incubator.
Mm-hmm. Yeah, I mean, for instance, with acne vulgaris, you could have a patient on doxycycline for 3 to 6 months. It's a long time.
Actually, there was a study done. I won't mention the institution, but it's a well-known, high-quality academic institution. And they did a retrospective analysis of their acne cases, okay? So this isn't coming from Doc in the Box in a shopping center. This is from a high-quality, well-known institution. And the average that their acne patients were on antibiotics was just shy of a year. And we know from studies that were done mostly in Scandinavia that exposure to antibiotics of 2 weeks duration, 2 weeks, can lead to changes in gut flora. Those gut flora can pass on that resistance to other microbes. And if you get that to 3 months, you're really pushing the window because you're going to have so much resistance, it can last for years. So we do need to be very, very cognizant of that and careful with our use of antibiotics. We all need to be less cavalier than we have been in decades past.
Thank you for sharing that, because it's a very important point that I don't think is brought up often enough. And this leads me to my next question. Do you see any hope for the development of a syphilis vaccine in the future? And why hasn't this been done already?
There's been some work done on it. It's somewhat difficult. Some organisms are more amenable than others to developing a vaccine. It's not been terribly successful to date. There's also been, it's just like herpes. There have been attempts to get a herpes vaccine as long as I've been a doctor, which is going back to the War of 1812, I think. We still don't have one. HIV, we don't have a vaccine. There's only one trial now. There were 3 just a few months ago, and 2 of them were stopped because they don't work. So it's just for the nature of the organism, for whatever reason, it just seems to not have been very easy to try and develop a vaccine. So I don't know. And the same could be asked of gonorrhea, where you see, more than 10 times the number of syphilis cases. There were attempts to get a vaccine, and we don't have one yet. So I don't know. Now, I hate to leave people with a totally negative impression, because the vaccine technology has gotten so good that we might at some point be able to do that. For example, there was a vaccine that looked pretty promising for Staph aureus. That'd be great. You give everyone that vaccine as an infant, and then we have no more MRSA to worry about, right? But then it turned out it looked really good in small trials, and when they did a big trial, it didn't work so well. So, but the technology's better than it was. That's why we got the vaccines we have now for COVID, for SARS-CoV-2, in a relatively quick time. So we might. I would hope so, but don't count
Time will
on it.
tell.
Yeah, exactly.
So where do you see the future of STDs going? Like, is it concerning that now more people are having same-sex intercourse, that which may also, as you said, be a risk factor for the increase of STDs? Where do you see the future?
Yeah, there are competing forces here. So one is an interesting technology. So you can now do internet sex. And it used to be pretty rudimentary. You sort of watched each other have pleasure. But now there's actually, oh my God, it's 3D, and you can control what somebody has on them to give them pleasure. It's like cyber sex. It's a real thing. In fact, during the pandemic, sales of these things, they're pretty expensive, but have gone through the roof. So maybe if we do more of that and less real sex, we'll have some hope there. I do think once this pandemic goes out with hopefully a whimper instead of a bang, no pun intended, that we'll have the epidemiologists get back. They were queued up in 2018 and 19 to do really intensive public outreach education. I mean, things like putting signs on public buses. Syphilis is back, just to bring this to the forefront, to the front of the mind of people. And those campaigns sort of all disappeared because money is limited and money had to be spent on the pandemic. So I think once that's kind of over or controlled, you'll see a big public health push, which might be very, very helpful. I don't think we'll ever get rid of it. I hope we'll have a little better control. It's sort of interesting because education is so important, but then again, parents want to be involved now in the education of their children, but some of them see STD education as being pornographic.
Mm-hmm.
But I often tell parents, and I've spoken to some parental groups, look, your kids are going to do it anyhow, whether you like it or not. And it doesn't matter what the color of your skin is or your socioeconomic standing. Hormones are hormones, man. So it's going to happen. Wouldn't it be better to educate them so they do it responsibly with, protection and only with partners they know or could be traced down if needed, and so forth and so on. So I hope education will help catch up with this as well. One more point I'd like to make, and that's STDs span spectrums. We talked about 15 to 24, but the youngest person I've ever treated personally for gonococcemia, so that's gonorrheal sepsis, was 9.
Wow.
And I've treated a 13-year-old for syphilis who got it from a 20-year-old who was teaching him how to have sex.
Wow.
It's kind of interesting. And the other side of the spectrum as well, I think it's great that we have things like Viagra and Cialis and so forth, but you never count out somebody for an STD diagnosis based on age, young or old. And in my present position, I see a number of patients over 70, even over 80 with syphilis. So, because, hey, they've rediscovered their genitalia and with a little blue pill. And so all of a sudden it's, whatever. And I think the interesting thing is that the University of Michigan, my alma mater, big shout out to Go Blue, even though they lost to the Green recently, but they did a study on sex over 60. And it was interesting that half of people over 60 think about sex every day. Uh, you know, a lot of people think that that's an important part of a relationship. People get divorced. Our divorce rate's about 50%. In the US, they find a new partner, and, you know, that partner may not be someone they knew too well. You know, older people can get disease, including syphilis too. So it's that 15 to 24 is your high suspect group. A little older than that, and including that group in gay and bisexual men. But anybody can get an STD. And so you never eliminate that as part of the differential diagnosis of cutaneous lesions based solely on the person's age. That's a big mistake.
Don't be biased is the takeaway.
Correct.
And especially as our population ages.
Yes.
You might see that number go into the 90s from the 80s.
Yes. And I might mention, I won't mention the denominations, but over the course of my career, I've treated a dozen men of the cloth. So, and it spans all the spectrums. So whatever your religious proclivity, your folks can get it. So, you know, the bottom line is, again, you're right. Don't be biased. Don't shut your eyes to that as a potential problem, and especially in dermatology. You see a rash, you don't know what it is right away. You see a genital lesion, you don't know what it is right away. Always keep syphilis in your differential diagnosis.
This was so helpful, Dr. Rosen. Thank you for enlightening me and many people who will watch this. Before we end, I would just love to ask you, as a dermatologist, what inspired you to specialize in STDs?
I'm going to go back just one step earlier and answer a different question, which is what inspired me to go into dermatology. So I was in medical school and I was taking my mandatory dermatology rotation. I had no intentions of going into dermatology. I was going to be an oncologist. And my then girlfriend, who's now my wife of 40 plus years, I think it's 45 this coming year. Anyhow, I was visiting her at home and her father came home. Her father was a lawyer and he hated me because I was a medical student. I don't think a lot of lawyers hate doctors, but sometimes they do. And he did. And he said, "Hey, hotshot." He lifted up his shirt. He said, "I got a rash." He said, "I bet you don't know what it is." And I said, in fact, since I'm taking I just actually finished my derm rotation. I said, "Yeah, that's erythema gyratum repens. It's a very rare manifestation of internal cancer. I think you need to go have a workup." He said, "Well, my primary care doctor said it's just eczema and gave me this tube of triamcinolone. I'll try that first." He had occult colon carcinoma, adenocarcinoma. And I was so impressed that I could make that diagnosis by something I learned in dermatology, that I changed my career goals. I thought that was so cool.
That is.
And then, you know, so that's why I went into dermatology. And then, you know, why interest in STDs? We were mandated as derm residents to go to the STD clinic, our local, the same one I ended up being the chief of years later. And I just thought it was fascinating because what they did, because, you know, we were all derm residents and we rotated through there, they allowed us to bring biopsy equipment. So if we saw something we didn't think was an STD, we could do biopsies. And the then pathologist was so kind. They would read those biopsies for free. And then, you know, we could call and make sure that the diagnosis was notated on the chart and that someone from the clinic or we would call them and tell them what to do, where to go, get help, and so forth and so on. And I just thought it was so fascinating because, you know, people don't see their lungs when they're smoking. They don't see that early bronchogenic carcinoma. They don't realize they're going to get COPD, but people see their genitalia. And relieving someone of pain or anxiety or discomfort or burning or stinging or itching when it's scabies, making someone feel better in an area that really counts to them, I thought was just absolutely fascinating. And, in dermatology, since I was going into dermatology, right, if you're not 100% sure, there are lab tests, and including our favorite thing, which is a skin biopsy. And you don't need very much, 2 or 3 millimeters, and you can find out what something is. And genitalia heals incredibly well. It's warm and moist, and it doesn't leave scars. I do punches and I close them with a suture. So I've never left anyone with a, unsightly problem in an area that's important. So I think it was a combination of interest in infectious diseases in general. I like infectious diseases. You make the diagnosis, you treat it. Either they get better or die. But it's pretty clear cut once you've made the diagnosis what to do. So I like that. I like the idea that on the genitalia, there's kind of a limited, it's big, but it's not unlimited diagnostic differential. And you can almost always come to an answer. And then you can relieve people of discomfort and anxiety. So I think it was a combination of all those things why I've maintained this interest long after residency.
Well, I think it sounds like you found the right fit for you, and you're doing great work helping many people and patients. And I feel inspired by talking to you today. So I thank you for coming and joining us and sharing your background and your knowledge.
Oh, my pleasure. I hope the listeners will enjoy this, and I hope they'll be inspired. There's a lot to be said for cosmetic dermatology. It's a great thing. You do make people feel happy, but there's another thing to be relieving real disease, among which are infections and a subset of which are STDs. And I just want to close my remarks with this comment. There's an old phrase, if not now, when? If not me, who? If not us in dermatology, who do you think is really going to do a good job with STDs? It's not going to be the urologists who are plumbers. It's not going to be the gynecologists who are busy with cancer and baby delivering. And it's really not even going to be the ID people who are really busy with HIV. It's got to be us.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.